everywhere we turn, Omicron and the COVID pandemic dominate the conversation. Just today, the U.S. Food and Drug Administration authorized Pfizer's COVID-19 vaccine for booster shots in 12 to 15-year-old kids. This is happening against the backdrop of young people returning to classrooms after the holiday break. So to help us make sense of this latest iteration of the fight against COVID, Dr. Angela Rasmussen, virologist at the University of Saskatchewan, joins us now. Dr. Rasmussen, thank you so much for joining us. If you could start us off by giving us your quick take on what today's news from the FDA means. Do you see it playing a meaningful role in slowing the spread?
I do. And part of the reason for that is that we've known since really Omicron emerged that 2 doses of the vaccines or being fully vaccinated does still provide significant protection against severe disease. However, the effectiveness of the vaccine has gone down considerably in terms of preventing infection altogether. Adding a booster shot really raises the levels of neutralizing antibodies, which are essentially your first line of defense against being infected. So that should improve the vaccine effectiveness at preventing infection as well as protecting against severe disease. During a time when people are going back to school, when kids are going back to school, and they will be in situations where they may be exposed to Omicron, it's important that they go back into those situations as protected as possible from infection as well as from disease.
Right. And you've now just enabled a larger portion of the population to be boosted as well. The FDA also pushed back the booster timeline from 6 months to 5 months, cutting it by 1 month. So millions of people are now 5 or 6 months out from their booster jab as a result as well, those who got their boosters early on. Now that the CDC is adopting this perspective of the sooner the better for these third shots, where does that leave us with regards to a fourth shot for people who are now, say, 5 to 6 months out from their original booster shot?
As far as I know, this isn't something that's being actively considered here in the US, although in Israel, healthcare workers and some subsets of vulnerable people have been offered a fourth shot. I imagine that if that does seem to be very effective in further decreasing transmission, that is something that would be on the table here. But for right now, I think that it's really important to concentrate on making sure that people get their third booster, since there's still a lot of people who have not received a booster shot yet, as well as vaccinating those who remain unvaccinated.
Got it. Got it. Taking a step back here, when we look at what's happened in South Africa, we've seen Omicron peak there. It ripped through the country, and then now it's on the decline. Do you expect to see the same pattern playing out in Europe and then the U.S.?
So far, it is looking, based on data from Europe, that is probably the trajectory of this. Omicron does spread incredibly fast. That means that in any given community, that should peak relatively quickly. But I'd caution people into saying that that's directly translatable. We're not going to go through one peak as an entire country all at the same time. New York is a couple of weeks ahead of other cities within the U.S., and certainly it will take some time for Omicron to be distributed throughout the country. So I think we'll be seeing a lot of different quick peaks of Omicron across the country in different communities, depending on when Omicron begins spreading there.
Gotcha. Okay, well, so far we've also all observed how Omicron is more transmissible than previous variants, including Delta, but so far it's also more mild. It's less virulent. So there is an argument that perhaps we don't need to be, I guess, as cautious about this variant, maybe let it spread so we can get it over with. The argument being that let it chew through the population, let people build up some natural immunity. You are an expert virologist. Does the science back this idea up?
The science absolutely does not back that idea up. For starters, Omicron may not actually be less virulent in unvaccinated people or people who've had no prior exposure to SARS coronavirus 2. Some data came out of Ontario today where there's also a huge Omicron surge occurring. And that showed that there really wasn't a difference in the number of cases between vaccinated versus unvaccinated people, but overwhelmingly the people who are being hospitalized, the people who are in the ICU are unvaccinated people. So I don't think we should make the assumption that Omicron is actually milder. It's just that people who have been vaccinated or who've had a prior infection are going to be more capable of controlling the disease. Now, that said, I think that it is really important to focus on what the numbers mean too. So anytime that we have a variant whether it's milder or not, that is causing a lot of cases, that means that there's going to be a lot of hospitalizations. And we're already seeing signs that healthcare systems in many places that have been going through large Omicron surges are being very strained. So even if it's an overall lower percentage of people who are becoming severely ill and requiring hospital care, if there's a lot of cases, that still translates to an absolutely large number of people. So we really should not just let it rip through the population and consider this a free booster shot. I think we need to do everything in our power to stop transmission of Omicron, just like we would for any other variant.
Okay, I hear what you're saying here. However, anecdotally, all signs are so far that Omicron is more mild than Delta. Having seen that Omicron is more transmissible, but apparently more mild, less virulent, what does that tell us about what the next variant might look like? Do variants evolve in a linear fashion?
No, so evolution doesn't occur in a linear fashion, and it's a very frequently repeated myth that viruses naturally become attenuated the longer that they circulate in a given host population. So again, Omicron is not necessarily milder. It's milder in people who've been vaccinated and have immune systems that can mount a rapid and competent response against it. That's different than being milder, actually. And the reason why this is important is that Delta did cause increased breakthrough infections, but the pattern of severe disease is essentially the same for Omicron and Delta. Omicron's infecting more vaccinated people, but the people overwhelmingly who are ending up in the hospital because of it, just like with Delta, are people who've not yet been vaccinated. So I think regardless of what new variants might come out, now they do seem to be under selection for variants that are more transmissible, which is no surprise because a virus's basically only function in the world is to make more copies of itself and be transmitted from host to host. I think that we can expect future variants to potentially be more transmissible. Their virulence is a matter of question. But one thing we do know is that the immune system is mounting responses that are very cross-protective in terms of preventing disease. So the vaccines that were developed against the original recipe SARS coronavirus 2 are actually still quite effective at preventing severe disease caused by Delta and by Omicron. So I think our focus really needs to be not worrying so much about what variants might be like, but focusing on getting everybody immunized as fast as possible to prevent the impact that those future variants might have.
Thank you for explaining that distinction. And again, the message from the medical community remains consistent, which is to get vaccinated, to get your booster shots. You, I know, study vaccines, Dr. Rasmussen. Will the pandemic only end once we've invented some kind of pan-variant vaccine that will cover all existing and, hopefully future variants?
Well, I know that the vaccine manufacturers are developing variant-specific boosters, and they've actually already tested them. Back in February, Moderna tested a beta-specific booster. But as I mentioned, the vaccines are still really holding their own in terms of their ability to prevent severe disease. And ultimately, that's what we really need vaccines to be doing. It's not so much just preventing infection. That's certainly wonderful when a vaccine does that. But the real risk here is making sure that we're keeping people out of the hospital, making sure that we're keeping people out of the morgue. And the vaccines are still largely doing that. So I don't think that we're going to be waiting for a pan variant or a universal SARS coronavirus 2 vaccine to end the pandemic. I do think, though, the end of the pandemic is going to be dependent on vaccinating the entire world. And in many places, we're severely behind in terms of our ability to do that. There are some countries where a very, very small percentage of the population has received even one dose of vaccine. So if we want to focus on ending the pandemic, it's getting vaccines into arms, period, not necessarily getting variant-specific vaccines into arms.
Understood. There's also an argument out there that we don't really have a good read on how widespread the virus is in the U.S. due to at-home testing. Even though we're seeing spikes, it's just what's been reported. Other people say we should look at hospitalizations as the best way to gauge the state of the virus in the U.S., not case counts. I'm curious what statistic you look at, you rely on, you find most helpful in framing your understanding of where we are at right now.
Boy, I wish there were just one. I think that we need to look at all of those things. Certainly it's going to be different from one community to the next. And that's going to depend a lot on demographics, the relative risk of people who are living in a given community. It's going to depend on how many of those people have been immunized. It's going to depend on how many COVID surges have gone through the population before, how much population immunity there is. certainly when we're thinking about how this is impacting all of us, we have to look at the healthcare system and see how much strain it is under. And certainly in places like New York City, the healthcare system is being very, very strained. We don't necessarily have to have the most accurate count of cases to understand this, especially since in highly vaccinated or highly immunized places, we're starting to see the hospitalizations decouple from the number of cases overall. But I think it is really important to maintain a look at what's going on in our hospitals, where we're at for capacity, and how fast cases are spreading too, because certainly part of hospital capacity is the ability to staff those hospitals. And if everybody's getting COVID at the same time, whether they have severe illness or not, that's a huge problem in terms of the healthcare system's ability to manage the incoming COVID cases that are serious.
Yeah.
So I think that really the answer is D, all of the above.
With demand spiking and also supply limited, that's what you're going to get. I'm curious also to hear about your thoughts on where we are at when it comes to testing, because some people say with Omicron, the rapid tests don't work as well. Others will say that the PCR tests don't necessarily pick it up. Can you help us understand how reliable current tests are?
Yeah, so this is something that is definitely an emerging area of research. There has been some preliminary data reported that the rapid antigen tests are less sensitive for Omicron, but they do still detect it. And that's actually expected because most of the rapid antigen tests detect the nucleocapsid protein of the virus, which is produced in really high quantities. And importantly, in Omicron does not have nearly as many mutations as the spike protein. Now, the molecular tests, the PCR tests, are a little different because each one of them is different. And some of them do not work to detect Omicron because they're based on the genetic sequence of the virus. If they look at a part of the virus that's particularly mutated in Omicron, those those PCR tests are not going to pick those up. So it really is an area where we definitely need more information. The FDA is providing information on which molecular tests are not effective. And so places should continually, people that are providing clinical care and those tested people should continually check with the FDA to make sure they're using tests that will detect Omicron. But I think that, really with testing, the moral of the story is that we're not anywhere near where we need to be. We need to have access to testing nationwide. We need to have both rapid tests and PCR tests accessible to people. And right now, rapid tests are very, very difficult to find in many parts of the country. Yeah. The turnaround time for PCR tests can exceed sometimes 5 days, which is completely unacceptable in terms of being able to make a decision that is really dependent on the results of that test, whether you should isolate or not, whether you need to be prescribed medication. All of those things are really dependent on having access to fast, reliable testing. And we have a long way to go in that department.
I wonder if that uneven reliability of tests has to do with what the CDC decided to shift its isolation guidance for asymptomatic positive people from 10 days to 5 days. Dr. Fauci suggested that these people who are asymptomatic but tested positive may have to get a test at some point. That followed a lot of backlash over the CDC guidance. What's your take on the 5-day isolation guidance from the CDC? What do you think is the strategy behind it?
So I think what you just said is exactly the strategy behind it. That's why a testing component wasn't included. I think that the rationale here was the concern that so many people would be required to isolate for a 10-day period of time that we would stop having access to essential services, and not just healthcare services, but also things like public transportation, grocery stores, things like that. We've already seen a number of flight cancellations, for example, right at the peak season of holiday travel, because people are testing positive on the cruise of different flights, and they're not able to actually staff those things. So I think the motivation behind that guidance was to make sure that people could actually go to work. Now, the problem is, and I understand, I guess I'll back up. I understand why the CDC did not include a testing component, although I don't agree with that. And the reason they didn't include a testing component is, of course, because tests are very difficult to get. PCR tests, the turnaround time is long, and rapid antigen tests are sold out in many places. So it would be very difficult to practically implement a testing component to this. But that said, I think that it still should include a testing component, because while the majority of transmission does occur prior to symptom onset and immediately after symptom onset, that's probably going to resolve by 5 days after infection. I know a number of people anecdotally who have reported that they're still testing strongly positive on rapid antigen tests well after 5 days into their isolation period. Now, the rapid antigen tests are not a pure correlate of whether or not you're contagious or potentially able to transmit the virus. But I would say that those rapid tests are less sensitive. If you're getting a strong positive more than 5 days after, that does suggest you still have actively replicating virus in your nose, and that test is picking it up. So that, to me, suggests somebody who should still isolate regardless of what their symptoms are like.
Thank you so much for explaining all of that. Dr. Angela Rasmussen, really appreciate your time joining us.